If you hadn't yet, please introduce yourself in the chat. It's wonderful to see folks in different roles joining us from all across the country. My name is Dana Fleitman. I am the Senior Training and Awareness Specialist at SPARC, the Stalking Prevention Awareness and Resource Center. And I'm delighted that I am not presenting alone today. I am joined by Lacey Smith. Lacey, do you want to introduce yourself real quick?
Sure. Thanks, Dana. I'm really excited to be here. I'm Lacey Smith. I'm a forensic nursing specialist at the International Association of Forensic Nurses.
Great. And so you'll be hearing a little bit more from me earlier in the presentation, a little bit more from Lacey later in the presentation, but we've also agreed to interrupt each other. And so we're not fighting. We're doing it. It is something we've discussed ahead of time. And of course, today we're talking about the health impacts of stalking. So I do training on stalking all across the country for audiences including law enforcement, victim services, campuses, and now medical professionals through this new project. And I usually start by asking this question, which I'm going to launch here as a poll, and that's, have you had the opportunity to attend previous trainings focused specifically on the topic of stalking? So not one where stalking was mentioned, but one that was like, we're actually just going to sit down and just talk stalking today. So I'll give you a few seconds to fill that out. I'm seeing the answers come in. Okay, I'm shutting it down in 5, 4, 3, 2, 1. Okay, great. So it looks like we have a range. We have several folks, about 1 in 5, saying, "Ooh, I've been to several of these." In which case, if you're thinking, "I could be leading this, I don't know why I'm listening to you, Data." We all bring a lot of expertise to the work, and you're the ones on the ground actually doing this work every day. So whether this is your first or millionth stalking training, of course, feel free to share your expertise. Your insights, what's working, what's not working in your community in the chat, because it's really great to learn from everybody. But I'm seeing for about half are saying, I've been to maybe 1 or 2, and about a third are saying this is my first stalking training. And not that you aren't special, because you are, but I find that that's pretty typical, that often a third to half to sometimes the whole room when I'm doing a stalking training haven't had the chance to be trained on this topic before. And that's not a reflection of anyone as an individual, but it is a reflection that stalking is very undertrained in our field. And we want to remember there are 4 major crimes under the Violence Against Women Act. It's domestic violence, dating violence, sexual assault, and stalking. But it's always kind of like and stalking, like we almost called our website andstalking.org, because so often it's like, oh yeah, and stalking, that's kind of in the mix. It's sort of part of the screening we do, but it doesn't get a ton of attention. And when you think about it, there is no national stalking hotline. There are few, if any, standalone stalking crisis services. So it often falls to folks like you who are often primarily focused on intimate partner and or sexual violence to kind of add stalking on. And I'm not saying that's fair or easy, because you're already busy and have plenty to do within those issue areas, as well as our healthcare professionals dealing with a wide range of health issues. But it is important because these stalking survivors really have nowhere else to go. And there's very few intuitive entry points for our stalking victims to get the help that they need. And so, look, you're the ones, like I said, doing the work every day. You know how to do what you do. My hope's just by the end of the session, you kind of move that and stalking a little more to the beginning of the sentence and see some of the critical work that you're doing through that lens with a few new tools, ideas, and insights. So this is under our Vital Signs project, which we're really excited about. It is a new grant that is specifically for educating healthcare providers on recognizing and responding to stalking. And so we have a couple things we've developed. We have a fact sheet, infographic, and video, but we're working on a lot more. So we'd love to hear from you, especially our healthcare folks on the call. What would be helpful? We're prioritizing some screening questions, and so we're working on those right now. But this is the first of many resources that we hope will help better integrate stalking into the healthcare response. So Spark's website, which is where I'm coming from, is stalkingawareness.org. There we have practitioner guides, and those are broken out by discipline, including a new section for healthcare providers. We also have for victim services, law enforcement, etc. We have training modules. So if you do any kind of awareness training, lunch and learn, that kind of thing, in your facility or your partners do. If you're talking about healthy relationships, consent, you want to be talking stalking as well. And so we have scripted programs you can pick up and lead with videos and scripts and slides. We have discussion guides on all 4 seasons of the TV show You. I'm watching the last season now, and other ways that you can integrate stalking education into the awareness work that you're doing. We are not a direct service provider, so please don't refer victims to Spark for anything other than resources that are informational, because we'll just have to be nice and send them back to their local. But we do have resources that y'all can share with victims. For example, these brochures on understanding stalking, we have in English and Spanish. You can order them for free from our website and put your local information here. We're developing a healthcare specific one as well, so that, if you have something in your lobby on domestic violence, sexual violence, make sure you have something for your stalking survivor as well to start that conversation. And webinars. So this webinar will be hosted on our archives, and we're called Spark, so I got us to call it the Sparchives. So that was like the height of my career. So you can check this and other sessions out in the Sparchives anytime. We're also on social media. Our handle on there is at Follow Us Legally. If you get our sick sense of humor at Spark, we will not be scared. We want you to follow us, and sign up for our newsletter. As an anti-stalking organization, we will not contact you excessively or without your consent. So you have to actually opt into our newsletter, and it's one we send around quarterly. So I hope that you'll connect with us so that you can stay up to date on the new resources for this specific project, as well as all the work that we do.
Thanks, Dana. It's really hard to follow up to all of Dana's just great, I call them Dana-isms. So, but excited to be here from the International Association of Forensic Nurses. And you can see our website there, forensicnurses.org. The International Association of Forensic Nurses is the world's premier forensic nursing organization. Since 1992, we've led the world in defining the depth and breadth of nursing practice where the health and legal systems intersect. The association defines and advances the global research agenda to enhance nursing's evidence-based response to the needs of forensic populations. We work to develop, promote, and disseminate information internationally about forensic nursing science, and we serve as a global network for forensic nurses to exchange ideas, serve as mentors, and enhance their practice. And you'll see our social media information on my slide at the very end.
Hey, great. All right, so as a quick either refresher for folks who have attended previous training, or as at least what will to me feel like the short version of a definition, just to get folks on the same page, since we're talking about the intersection of stalking and the health impacts of stalking, what is stalking? So one thing to recognize up front is that stalking is criminal, it is traumatic, and it is dangerous. So stalking is a crime. It's a crime at the federal level in all 50 states, as well as the District of Columbia and all US territories. It's a crime on most tribal lands and in the military justice system. It might be a misdemeanor or a felony, depending on the jurisdiction and the situation, but it is a crime across the board. A lot of folks don't realize that stalking is criminal. So you have victims saying, well, what, should I call the police because somebody's ringing my doorbell or driving by my home? And of course, a lot goes into a victim's decision to engage with law enforcement or not, but many of them don't even realize that's an option because they don't recognize what's going on is stalking, and further, that stalking is a crime. And stalking is traumatic. Many stalking victims experience both mental and physical health issues, and of course, that'll be our focus today. Many lose time from work. 1 in 8 lose some time. About half of those lose 5 days or more. And stalking survivors are not typically a protected class of worker. So that's a good thing to check in your state. or territory, and many relocate. This really shocked me when I learned this, that 1 in 7 stalking victims move. So think how annoying it is to move when you want to move, right? It's expensive, it's stressful. It's not something you do because someone's kind of annoying you. We have 1 in 7 victims relocating to get away from these offenders, which I think helps to illustrate how traumatic and consuming this victimization can be. And stalking is dangerous. It often co-occurs with physical assault and sexual violence, including but not limited to rape. 1 in 5 stalkers use weapons to threaten or to directly harm their victims. And in 76% of intimate partner femicides, so that's murder of a female partner by a male partner, in 76% of completed and 85% of attempted, there was stalking the year prior to that homicide or attempted homicide. And yet, these stalking behaviors are often dismissed and minimized as not real violence. There's this sense of, oh, it's annoying, it's frustrating, but no one's really getting hurt here. And that's simply not true. In fact, this wonderful researcher we work with, Patrick Brady, went so far as to say that stalking is homicide in slow motion. Now, I'm certainly not saying that every stalking case escalates to the point of violence or homicide, right? That's not accurate. What I am saying is that every week I read cases of violence, attempted violence, homicide, attempted homicide. And at that point, responders often start looking backwards and saying, oh, look, there's this whole history of stalking victimization here. Often that was reported to multiple sources, but was not handled with the urgency needed. So we don't want to do that, right? We don't want to wait for violence and then say, oh, that must have been the stalking that they were talking about all along. No, we want to identify the stalking and intervene then, because this is one of the few victimizations that can help prevent further trauma, violence, injury, health impacts, and possibly even homicide. So what is stalking exactly? Depends who you ask, right? When you have your state statutes. And so we have a map on our website where you can look up your local statute, which I encourage you to do. But we're talking behaviorally today because whether law enforcement chooses to charge and your prosecutor chooses to charge stalking or not, you still want to know when that's the behavior happening, because this is the behavior that is having the kind of impacts on victims and survivors that we're talking about today. So behaviorally, stalking is a pattern of behavior directed at a specific person that would cause a reasonable person to feel fear for their safety or the safety of others, or to suffer substantial emotional distress. So to break that down a little bit, it is a pattern of behavior that's not a single incident or one-off event, and that's called a course of conduct in most statutes and policies. So you might hear me use those terms kind of interchangeably today: pattern of behavior, course of conduct. I'm talking about the same thing. It's typically 2 or more behaviors that make up that pattern. There's a couple states that require 3 or more in the statute, but behaviorally, most places it's 2 or more. And those behaviors can be quite varied. So let's say I'm stalking Lacey because I'm the worst co-presenter ever. Okay. So maybe Monday I text Lacey. Tuesday I'm mad she didn't respond. I smash her headlights. Wednesday I feel kind of bad about that. So I send her flowers. All of those are stalking behaviors. And so stalkers often combine acts that are crimes on their own, like that property damage, with other behaviors that may not be criminal on their own, but can become criminal in the context of a stalking case. So that's confusing because no one thing is stalking. We have to zoom out. And when a patient or victim or survivor, depending on your role, is talking to you, they are likely to lead with the most recent incident that led them to come in that day. And our system tends to be pretty incident based, right? Our officers, for example, are responding to a call for service. So I really recommend that you zoom out and be thinking, is this an isolated incident? Is this part of a bigger pattern of behavior? Because a victim who's telling you about, say, their smashed headlight may or may not think to automatically disclose to you, oh, I think I know who did this, and they've been texting me a lot. And I've been getting weird stuff in the mail lately. And my email's been acting weird. I think someone hacked in there, right? They may or may not just automatically share that because that's not what we're talking about. But it needs to be because it's letting you know this is not an isolated incident. It's part of a larger pattern of behavior. And this could actually be a stalking case. Stalking's directed at a specific person or person, so it's not random. It is they're choosing a specific target. That being said, we often see what we call target dispersion, which is maybe you have, say, an ex stalking their ex-partner, ex starts dating someone new. Okay, so now they're stalking their ex and that ex's new romantic interest. And our stalkers are trying to get access to and information about their victims, right? So they're likely to reach out to a victim's community, their friends, their family, as well as medical professionals that might be working with them, to try to, their colleagues, to try to get that access and information. So a lot of folks can be involved or even considered co-victimized in a stalking case, but we still see that behaviorally as directed at a specific person because they are trying to get to that victim and they might use other people to do it. And it would cause a reasonable person to feel fear. So fear is really important to understanding stalking. And it's actually what separates it from a victimization it's often confused with, which is harassment. And harassment can be quite serious. I'm not trying to minimize it. And it might be the more strategic charge, depending on where you're located and what's going on. But they're a little bit different in terms of the behavior, and that harassment is typically that repeated behavior that would make someone feel frustrated, disrespected, demeaned, annoyed, create a hostile environment, but it's not necessarily scary. So if my supervisor is emailing me at 3 a.m. and then yelling at me at the staff meeting at 9 a.m., like she's terrible and I hate her, I'm not necessarily afraid of her. I'm just like, oh, she's the worst, right? Like I don't deserve to be treated like that. But let's say that I'm driving home. I think I see her car a couple back. She texts me a picture of myself walking my pug, says, why are you doing that instead of working? She emails my husband. I don't know how she got his email. Now I'm scared, right? Because she's in all these aspects of my life. Will this escalate? What else does she want from me? Like, my life does not feel safe from this person. And so harassment can become stalking or be part of the course of conduct, but they're a little bit distinct. And I think that's important for a couple of reasons. One is that stalking's a higher charge than harassment generally. So when we are working with criminal justice, we want to have that option. And the other is that our victims of stalking are at greater risk of violence than our harassment victims. And the kind of fear they're experiencing is different and has different impacts on their mental and physical health than our harassment victims. And so we want to call it what it is so that we can respond with the right level of urgency and apply the right tools there. So again, it's about fear, but fear of what, right? And so our behavioral definition includes fear of bodily harm. And that, of course, includes sexual violence. So fear of harm to self or others, as well as emotional distress. So emotional distress is also about fear. It's just recognizing that fear may be of outcomes in place of or in addition to physical violence. You might be afraid of losing custody of your children or of never having a safe moment alone again, right? So people experiencing emotional distress, it's not just having a bad day. They feel that their life is being invaded, that they're being sabotaged, that they're being threatened, that they're under surveillance. The best quote I saw about it was the victim who said, it's like he's taken my life without killing me. So that sense of living in fear and not knowing when this person will come back and how much they will continue to take from you. That's what we're talking about when we talk about emotional distress. Again, it's about fear. But fear is tough because fear is very personal. What's scary to me may not be scary to you, right? And vice versa. So we're going to watch. This is literally a 5-second video and think about which of these folks you relate to more. Yep, that's it. So some of you might have felt more like the lady in this video, in which case, I'm sorry I did this to you. Someone the other day was like, where was the trauma warning on that, right? So with apologies to those who hate spiders, most of us, I think, can understand where this face left here on the screen is coming from, right? It's this tiny thing. You're losing your mind. And especially folks here who've seen the worst of the worst working with victims and offenders who may be coming from emergency medicine, right? You've seen so many bad things. You're like, this lady, okay, overreacting, right? Um, but what if I told you that the same woman was bit by a spider last year that looked just like that, had a terrible allergic reaction, went to the hospital, and almost died? We still be making this face at her? Hopefully not, right? Outwardly, because what did I give you there? The context, the backstory. And context is critical in stalking cases. It's really everything in stalking cases because a lot of times what's scariest or most distressing to a victim may seem benign or even kind of nice to you as an outsider. Um, and so something may be scary to the victim, but not to you. So, what you want to do is respectfully ask that victim, what message did that send to you? What is the story behind that? Because those behaviors often have specific meanings only understood between the victim and the offender. The classic, albeit an extreme example, is an offender saying something like, I'll send you roses the day I kill you. Right? So the victim gets flowers, is terrified. Everyone around the victim is saying, oh, that's so nice, because they don't know about that specific meaning. And so it's context that makes stalking scary, and it's context that makes stalking stalking, because generally no one thing is stalking. It's about zooming out and seeing, oh, what are the other behaviors and how are they adding up? And also, it criminalizes otherwise non-criminal behavior. It's not generally a crime to send someone flowers. It generally is a crime to make a credible threat to kill somebody. So when one means the other, we have to explain that, right? Because this is how stalkers get away with their behavior. You have responders kind of saying, well, flowers aren't threats. I don't know what's wrong with this person when they're so upset. And yeah, not always, but they can be. It all depends on that context. The reality is, if a victim's afraid or in distress, even if you're like, ooh, I'm trying to empathize here, but I just don't get what they're so concerned about, the truth is they probably know something you don't. So we're going to watch the next few seconds of this video and see how it plays out. All right, so obviously a silly video, right? But we don't want to be that guy. And this happens in our stalking cases all the time. We have a victim in a lot of fear and a responder kind of minimizing it. One who was on point the whole time was our victim. There is no better risk assessment than a victim's own fear. So if they're afraid or in distress, they probably know something we don't, and we need to dig a little deeper to get that information. But is it fear? As you already know from your work with victims and survivors, they react to trauma differently, right? Some might present as really angry or be laughing about the whole thing or be really flat, have no affect at all. And the truth is, most people won't use the word stalking or fear. Um, they're more likely to say something like, my ex is being creepy, a neighbor is making things awkward, an old friend is doing too much, right? This patient's making me uncomfortable. And it's also quite a vulnerable thing to say, I'm feeling scared, I am fearful. We're more likely to say, like, I'm worried, I'm annoyed by, I'm frustrated with, right? And so it's really up to us as responders to be thinking, could this be stalking? Could this be fear? It's also tough because there's often a lot of minimization that our victims do because of the messages they've received, in which stalking is so often minimized and laughed off, right? So, for example, this law enforcement officer shared this story with me. They were the regular point of contact for a stalking victim. They call to check in. Victim's in a really good mood. And the victim said, today's a great day. He's only driven by my house 10 times. And the officer's like, that's ridiculous. It is 9 in the morning. What do you mean it's a good day? And the victim said, oh, but usually by this point, he's driven by like 20 times. So I think it's going to be a low key day. So it's not that this victim's unreasonable, right? But she is responding to repeated trauma by normalizing what to most of us would be really scary. And that's where behaviorally that reasonable person standard's kind of helpful, because if you have a victim saying, oh, it's fine that they're in all my accounts and they follow me everywhere, as long as they don't bother my kids, right? You can kind of take a step back and be like, is it fine? Or could this really maybe be fear, really maybe be stalking? Another helpful way to assess for fear is to ask victims what they've changed as a result of the victimization. Because I've had victims say, I'm not scared or anything, it's whatever, but I changed my route to and from work. I changed all my locks. I changed my phone number. I blocked them on Snapchat. I blocked them on Insta. Oh yeah, I read all my passwords, and then I don't go out alone at night anymore. And oh, I told the building to like keep an eye out for him just in case. Okay, so those aren't things you do when someone's kind of annoying you, right? That's an indicator of a higher level of fear or distress. And I'm not saying victims should or should not make these changes. I'm simply saying many do. And frankly, this is evidence of fear. So ask about these changes. Have they done things like changed accounts numbers and settings? Have they spent money on new devices or accommodations? Do they have increased security or privacy measures? That could include the purchases as well as, oh, I used to take the public transit, but they'd wait for me at the station. So now I only take Lyft or Uber, or I don't go out anymore, or, anything that creates that distance. And financial impacts like losing time from work because they're dealing with the injury or the property damage, etc. So all of these can be indicators of that this person is experiencing real fear and distress, that they're going out of their way to avoid this person. Stalking is an extremely prevalent victimization in the United States. Nearly 1 in 3 women and 1 in 6 men experience stalking in their lifetimes. And if you're familiar with the data around sexual violence and domestic violence, it's very similar. So very similar rates here in the folks that you're working with, yet again, very few resources for them. People of all races experience stalking, absolutely. With our adult victims, we know that our multiracial and our American Indian and Alaskan Native folks experience particularly high rates, and that women experience stalking at higher rates than men do. Uh, as you might guess from your work in intimate partner and sexual violence, we often have a sense that stalkers are strangers, in our public imagination, but that's actually not the reality. About a third for our time for our male victims, nearly half the time for our female victims, that stalker is a current or former intimate partner. So it's often an extension of power and control from an intimate partner violence relationship. It can also be an acquaintance, a stranger, though it's relatively rare. It might be a brief encounter, like, oh, I met that guy at a party once, or, ooh, I think she works at that coffee shop. It could be a family member or a person of authority, like a supervisor, academic advisor, somebody like that. And unfortunately, health professionals as well are like more likely to be victims. I couldn't find a US based study, but there's multiple in other countries showing that our health professionals, and that includes psychiatrists, physicians, nurses, and others, experience even higher rates of stalking than the general populations. And many of these are those current or former intimate partners, just like they are for our general population. Um, but I just wanted to highlight, it could be a patient stalker as well. And most stalkers do not have significant mental health issues. Most do not have significant co-occurring psychosis. That's another misperception about stalking, is that it's just a mental health issue, when indeed that is not the case, just like sexual assault is not mostly a mental health issue, right? That being said, though, our medical providers are more likely to encounter that minority of stalking offenders who do have some kind of significant co-occurring psychiatric condition. And so we know that there is more likelihood of them being in touch with those folks and the victimization that might occur. And that could be about the nature of the work in terms of treating that part of the population, as well as just expectations about the engagement in the relationship and how unhealthy, and the sort of expectations that patients may bring, and the attachment that they may form to providers. And I'll hand it to Lacey to talk a little bit more about this.
Yeah, so I think in the current climate of healthcare, we know that workplace violence is increasing and is a real problem. And stalking can be a part of that issue, and especially in our healthcare facilities where maybe we're trying to manage that balance between avoiding harm or kind of breaking the patient's confidentiality and maintaining our safety as the healthcare provider, right? Um, so many healthcare organizations don't even have a procedure for how to manage stalking of a healthcare provider and what you should do if you feel that you're being stalked by a patient. And that can look really different depending on, of course, the person who is doing the stalking and on the healthcare provider as well. I know that I've heard from other nurses and physicians that patients have looked them up on social media and sent messages or found their home address on licensing board websites and contacted them in those ways, or shown up places. And those relationships can be difficult to manage. And Dana mentioned zooming out earlier, and really kind of recognizing that this is a pattern of contact from a patient can be difficult until you kind of look at it from that zoomed out lens. And it is this kind of weird balance between managing what is clinical and what's criminal, and how we manage these behaviors with a patient can cause those behaviors to escalate or can de-escalate those behaviors depending on how it's managed. I think it's really important for healthcare providers, especially those in management type roles and administrative type roles, to understand that we really need to have these procedures put in place to protect the healthcare providers in our organizations.
Oh, thanks so much, Lacey. And we're hoping to develop more resources in this direction as well moving forward. But it's something we wanted to flag here at the top that yes, this is not the majority of stalking. And this is a significant issue, like you said, around the workplace violence, especially when we're thinking about our healthcare providers. So stalking behaviors, there are so many stalking behaviors. We certainly don't have time to name them all today. I don't mean this as a compliment to offenders, but people always tell me that their most, not always, often tell me their most disturbing, bizarre cases are stalking cases. Because if you think about it, by definition, stalking is about going out of your way to scare somebody. That is literally the whole point, right? So like I read a case where an offender drove 300 miles to carve his ex's name in trees near her new home. Like that's a stalking case. Seen a lot of dead animals in the mail cases lately. Those are stalking cases. These like, ew, why? Do anything else with your time. Those are stalking cases. And so because stalkers are creative, we have to be creative in identifying what those behaviors might look like. One common stalking tactic is to break into a victim's vehicle or home and not take or break anything, but just leave some sign they've been there. So they might leave a can of the soda that's the brand the victim knows that that offender likes to drink. Or they move a lamp they one time argued about where it should go. And so the victim gets, let's say, home. They know that stalker's been there. But they're like, what am I going to do? Call the police and say someone moved a lamp? I'm going to sound crazy. And stalkers know that. That's why they engage in this behavior. In fact, 1 in 5 stalking victims reported that exact thing. Offender breaking into vehicle or residence and just leaving a sign they'd been there. And so if a victim ever says to you, I know it sounds crazy, but that's a red flag. This might be a stalking case. And what I tell law enforcement is I'm not saying don't investigate it, but I'm saying let's investigate it. Because if your victim's saying, I'm hearing voices, well, it's pretty easy to drop in on a lot of the smart devices that we have. There really are ways to do a lot of these behaviors. So I'm not saying don't look further, but let's not write it off right away either, because these stalkers really do engage in these behaviors that seem outlandish and like so much work. I think when a lot of folks think stalking, they think surveillance. So you got a lot of imagery of like binoculars or cameras. And that is a part of a lot of stalking cases, but it's not the only thing because anything scary that's not the first thing that's happened could be a stalking case. And so that's a lot of behavior. So these categories overlap and intersect, and that's fine. It's just to give us kind of a broader understanding and to think more about how these behaviors might show up. So surveillance is pretty much what it sounds like. Oh, and I'd say too, feel free to share in the chat any that folks you've worked with might have experienced, obviously with privacy in mind, but any general examples. So surveillance is pretty much what it sounds like. And oh, I'll mention too, I often get a lot of questions about the use of technology to stalk, and technology is often used in stalking. We provide training on that, and it's really important. But it's also good to know that most victims are experiencing both in-person and technology facilitated. So it's often both. And so good old-fashioned showing up, walking by, looking through the window, those are still really common stalking tactics. So surveillance is pretty much what it sounds like. How is the stalker tracking, watching, monitoring? I'm seeing some examples here, putting an air tag on the car. Yeah, putting some kind of tracking device, just watching them. Proxy stalking, which is a fancy way of saying stalking through third parties. So it might be calling that front desk and saying, "Hey, did they check in for that appointment yet?" Right. And that person just gives the information without really thinking twice about it. Sometimes those third parties know they're helping a stalker. So you might have an offender saying, "Well, I'll get in trouble, but you go deliver this message," right? And so third parties are giving them messages or leaving them things or taking pictures of them, etc. And sometimes those third parties have no idea. So it could be accessing devices that are already there, like say the person has some kind of camera in the home for their own safety. Maybe that gets taken over by the stalker. Now they're the one watching, or it could be planting a device on them as well as hacking into email and things like that. Um, Life invasion is how is the stalker showing up in the victim's life where the victim doesn't want them to be there. So the victim is trying to get through their day, and there's the stalker or signs of the stalker. So that could be unwanted contact um, across venues, across platforms, right? They're on Snapchat, they're on Facebook, they're on WhatsApp, they're commenting, they're liking, they're leaving voicemails. You sit down to do your job, they're in your work email too, just this constant trying to get to you, trying to get to you, trying to get to you. I see an example here. Oh yeah, getting an apartment right behind somebody, right? So that kind of showing up and inserting themselves into that person's life. And we see a lot of that, whether it's moving, like the example you gave, or even just like, since when do you go to this grocery store? Since when do you come to our kids' soccer game? Um, Leaving pennies around the car or home. Yeah, things that are just kind of some little sign, hi, I'm here, right? Remember me. Could also be leaving objects like the pennies or gifts or sending mail, etc. Um, and harassing and or trying to befriend other people around the victim. So many victims say, "Hey, when it was just me, it was fine. But now that they're talking to my new partner, my colleagues, my friend, it's really not okay." Intimidation, how is the offender threatening the victim? And this can be implicit or explicit. We do see those threats that are explicit, right? That I will harm you, I will do this to you. But we also see those implicit threats, like it could be a threatening gesture or a crushed can or symbolic violence. Like we had a case where an offender kept breaking into the victim's home and slicing her underwear with a knife. So that kind of symbolic sexual violence. It could be forced confrontations. I can't leave my apartment because they're standing right by the front door. I'd have to go through them to get out. Could be threats to harm themselves as well as others, family, friends, pets. And so all of that can be really scary. And I'd encourage you to realize that all these behaviors can be intimidating, even ones that don't seem like direct threats. Like if you got a text message after this webinar from unknown number that said, "Hope you enjoyed that webinar," and then described to you what you were wearing, that'd be pretty intimidating, even though it didn't say, "And I will physically harm you," right? And so all of these are intimidating, absolutely. Sending screenshots of a concealed carry license. Yeah, that's a great example. I mean, it's bad, don't do that, but very strong example. And yes, I'm glad someone mentioned that using the children to gain access or information. That's really common in our proxy stalking as well, especially when there's joint custody, right? Um, And last but not least, interference through sabotage or attack. What's actually changing in this victim's life? What are they losing or afraid of losing? How are they being sabotaged or harmed? So that could be financial and work sabotage, moving money around, hacking into accounts, calling and saying, guess who gave me terrible customer service today, or even parking outside the workplace so the victim doesn't feel safe going in. It could be spreading rumors, ruining reputation. We often see a lot of impersonation online. And so a stalker might pretend to be the victim and then, for example, share sexual images without their victim's consent, or, make a profile that says a bunch of uncomfortable things, or, all of that. Keeping them from leaving, it could be road rage, as well as that physical violence. It could be very tangible interference, like they slashed my tires, I can't get to work today. Um, or these other things that are keeping somebody from living their normal life. Um, so yeah, and thanks so much for sharing in the chat. These are all great examples and also highlight how far a lot of stalkers really will go in order to scare their victims. And so again, this is just the tip of the iceberg, just to kind of get folks thinking, because I think when people hear about, oh, I was run off the road in this road rage incident, they may not think, could this be a stalking case? But I encourage you to actually think about, okay, well, was that the only thing that happened? Not to minimize it, right? But what else might be going on here? Could this actually be part of a bigger course of conduct? Um, Speaking of technology, here are some of the most common technology tactics, and you can see that these also include those four categories, right? You see that unwanted contact, that life invasion, as well as that surveillance, just watching what someone does online. It could be those threats. I will post inappropriate or personal information, as well as that tracking. So really a variety of different tactics. And so we're currently developing screening questions for a healthcare setting that are a little more plain language than this, but they're based on these four categories. So basically, if you are trying to figure out, could this be a stalking case? Typically, if you asked, well, is this stalking? They're likely to be like, no, it's not stalking. Come on now. But if you ask about these more specific behaviors, surveillance, have they been tracking, following, or monitoring you in any way? Have they invaded your life or privacy with unwanted contact? You give some examples of what that might look like, right? And they may say, well, I don't know if they've invaded my life, but I mean, they text me all the time. Look, they're texting me right now, right? So you're likely to get more information if you ask more specific questions about the range of behaviors. And if they say yes to any of these, were we worried about your safety? Did you make life changes, those accommodations I talked about? And were you concerned about financial or social impact? And I'd add health impact as well. Now, of course, I know folks were serving different roles here. This kind of screening is not appropriate for everyone to do in every role. It's something that I always share with our um, domestic and sexual violence folks, but it's something that is helpful if you're just thinking through, could this be a stalking case? To remember to think about the diversity of behaviors. And if you hear kind of any upsetting incident, is this alone? Is this part of a bigger pattern of behavior? So really quickly, just on the intersection of stalking and domestic violence. So most stalking is not domestic violence related, but a big piece of it is. About that 30–40% of stalking, it's an intimate partner. So I want to focus on that piece here. If we look at our friend, the power and control wheel, which my guess is you've seen before, of course, this highlights different ways that an abuser can exert power and control over their victim. And so I show you this because often when I hear folks talk about stalking and domestic violence, they usually talk about it like this. They'll say, like, okay, it was an abusive relationship, the victim left, and from the day that victim left, our abuser began stalking them. And that can totally happen. But let's take a step back. If during the relationship, our abuser is contacting them constantly, showing up at work, showing up in school, asking friends and family about them, putting a tracker on the car, demanding all their passwords, threatening them, that's stalking, right? It's intimate partner violence or domestic violence is what we might call digital abuse or emotional abuse or coercive control. And it's stalking, it's both. And it can happen during and or after the relationship. over half the time, it's happening during the relationship as well. But folks often don't call it stalking then. They call it, emotional abuse or what have you. And we want to know when stalking's happening at any point in the relationship because while all stalkers can be dangerous, on average, our intimate partner stalkers are the most threatening and violent towards their victims. And so this doesn't match kind of our meta narrative on stalking. When a lot of people think stalking, they think like a hooded figure, very similar to the myth of the stranger rapist. But also very similar to that, actually, it's usually people that we know, right? And generally, the more information or access that someone has or had about a victim, the more threatening and violent they tend to be. So it makes sense that, no one knows us better than our intimate partners. And so they're likely to have the information and the access. Information that's really practical to stalk, like they know the victim's schedule, they know where they go to their appointments, they know the pharmacy they pick up their prescriptions from, as well as they know what will uniquely scare that victim because stalking is very personal and that's what it's about. And so if you hated the spider earlier, guess who knew you'd hate the spider? Your intimate partner, right? So when it's time to stalk you, it's spider time. It's not spider time for me. I don't care about spiders. They come after my pug, right? They're going to come for the thing I care about. Um, that being said, I wouldn't get too hung up on these categories. And here's what I mean by that. So, like intimate partner, no one uses that term besides us, right? Like no one's like, oh man, that you got to come over for dinner and meet my new intimate partner, right? And so when and we have a lot of relationships that are, oh, well, we're friends, but we hooked up a couple times, or we met on a dating website, but we didn't really hit it off romantically. Is that an acquaintance or an intimate partner? I actually don't really care. I think what's important is what access or information do they have about the victim and how committed do they seem to be to the course of conduct. Our intimate partner stalkers are the most likely to approach in person, use weapons, have their behaviors escalate quickly. And while the recidivism rate is high across the board for stalkers, it's the highest with these intimate partner offenders. And like I said right at the start, it's a lethality risk. Here's a more recent study reflecting that. It's one of the top 10 risk factors for intimate partner homicide. And so we want to know when this is happening. If they're coming in because of a stalking incident, that's a traumatic victimization in its own right, and it could be part of that escalation to lethality. Women who are abused and stalked had higher rates of all these different harms as well. So stalking is also an indicator of other kinds of harms, including sexual violence. Um, so in this study, all the women have been abused. All of them have protective orders. Some were abused and stalked. For the women abused and stalked, they have higher rates of all of these things, from verbal abuse to sexual violence, threat with a weapon, attack with a weapon, and injury. And so, again, when they're stalking, it's an indicator this partner might be especially violent. Speaking really quickly of stalking and sexual violence, just realize the co-occurring victimizations here. About a third of women stalked by an intimate partner were also sexually assaulted by that partner. And it's not only sexual assault itself, they also experience a variety of other forms of sexual violence. Here's that same study when there was abuse and stalking, higher rates of everything, including implicit threats, verbal pressure, degradation, and coercion, as well as forced substance use, which didn't make it on the slide, but it is also true. And so, again, I'm not saying stalking causes these other harms, but it's an indicator that if we have an abusive partner who's stalking, they might be particularly violent, including sexually violent, to that victim. And so, long story short, too late maybe, ask about co-occurring victimizations. Absolutely ask your stalking survivor about domestic and sexual violence. But if you're working with someone who's primarily presenting or coming to you as a survivor of sexual violence or domestic violence, ask them about stalking victimization as well, because so often it is missed and then we don't respond to the full scope of harm or see what might be coming next. So not only is stalking dangerous in terms of the direct harm, in terms of injury, attack with a weapon, being beat up, all sexual violence, all of those things, but it also has specifically health impacts that are quite serious. So I'll hand it over to Lacey to talk more about that.
Thanks, Dana. So as we kind of talk about the health impacts of stalking, it was really powerful to see what you all shared in the chat about different things that you've experienced with patients or maybe in your own personal lives. So as we kind of talk about on the next slide, this anticipatory fear, kind of think about some of those situations in your head and exactly how that might activate your fight or flight response or your stress response. So we're thinking about this from a healthcare perspective, and you're going to hear me use the term patient. I'm a nurse, so I'm going to be referring to these folks as patients. But when we're thinking about our patients that are coming in, whether it's for medical forensic care or it's for general health care, maybe in the emergency department, we're typically not, maybe in the medical forensic setting, but in other healthcare settings, we're not automatically thinking about violence or trauma or stalking, these different kind of victimizations. But if we think about patients that we have encountered that are telling us that they're having these chronic symptoms, they're always tired, they're always having an upset stomach, you know, really kind of trying to get to the root cause of some of that is so important. And as we think about how this anticipatory fear or, this fear that someone is going to do something like all of these behaviors that you all described, I can imagine and have experienced myself that each time this person attempts to leave the house, they're having this fear that something is going to happen. Each time their phone rings, they're having this fear of who might be contacting them, et cetera, et cetera. And we know that when we experience stress, our brain does things, right? So the amygdala or our emotional response system sends out a signal when we experience something that causes fear. And the amygdala is especially responsive to fear as an emotion, sends signals to the hypothalamus, and the hypothalamus is our command center. It kind of tells all of our systems what to do through the use of different hormones. So the hypothalamus, when it's stimulated, sends out signals to the rest of the body through the autonomic nervous system to the sympathetic nervous system and the parasympathetic nervous system. We're going to focus more here on that sympathetic nervous system or the gas pedal, what kind of drives us forward. Um, those signals go to the adrenal glands, and we know that the adrenal glands produce epinephrine and other catecholamines in that big surge of epinephrine that causes, that fight or flight response. And kind of once that maybe calms down just a little bit, the hypothalamus activates our HPA axis, and we'll talk about that a little bit more in a second. But the HPA axis causes the hypothalamus to release several different hormones all the way down through our nervous system to get to the release of cortisol. And cortisol is that hormone that we're seeing that's going to cause these chronic symptoms that patients experience when they are chronically stressed. And it makes me kind of think about a patient that I was talking with not too long ago. And they were telling me about all these different symptoms that they were experiencing, some memory problems, feeling tired all the time, having some GI upset, constant chest pain. And they were like, I went to the doctor and they were like, you're just probably a little anxious. Well, yeah, absolutely. And as we continued to talk, um, the patient told me a little bit more about what was going on at home. And we can go to the next slide. So we'll get to all that. But um, so when we think about the body systems, starting with kind of our are psychological symptoms that we'll see with patients when the body continues to experience those epinephrine surges that we talked about and the constant activation of that HPA axis. We know that there can be severe consequences. Um, these surges and the presence of that constant cortisol because of chronic stress can lead to higher rates of anxiety, of depression, post-traumatic stress disorder, suicidal ideation, intrusive thoughts, aggression, difficulty sleeping, frequent headaches, and vision issues. And I think the frequent headaches are an interesting symptom that a lot of specifically women have. And this chronic stress can really impact that frequent headache situation because that chronic stress is going to cause chronic muscle tension. It causes changes in the microvasculature of the brain. Epinephrine itself is going to cause those small blood vessels throughout the body. So think areas like the brain, the eyes, the kidneys, all of those areas that have microvasculature. Epinephrine is going to cause constriction of those areas to shunt blood to the vital organs, right? So that can cause permanent changes in the microvasculature in the brain. Um, Chronic stress causes changes in eating habits and, difficulty sleeping, and that can all kind of compound to cause a patient to have frequent headaches. And vision issues, I also thought was really interesting. So that prolonged increase of cortisol and other glucocorticoids, that's a hard word to say, um, and prolonged increase of epinephrine and other catecholamines can cause elevated intraocular pressure. I'm tripping all over my words today, y'all. Elevated pressure in the eye, sensitivity to light. We know that during that fight or flight response, the pupils dilate, can cause that to happen more often, and patients can become sensitive to light, can cause eye twitching, blurry vision, eye strain, tunnel vision, and even patients become more cognizant of floaters that they see in their eyes. Um, Moving on to the respiratory system, that same microvasculature, the constriction of those small vessels can happen in the lungs as well, can cause shortness of breath and some immune type disorders that we'll talk about with the HPA axis dysfunction can cause increased risk for asthma and other respiratory issues. Also, we know that during that fight or flight response, when the blood is shunted to the more vital organs, the heart is going to beat harder and faster, increases blood pressure, can cause patients to have chest pain, can cause heart palpitations, and can cause permanent damage to those vessels. Just the presence of epinephrine and norepinephrine can cause damage to all of the vessels throughout the body, and specifically in the heart, increasing the risk of heart disease, hypertension, heart attack, and stroke. And just a thought here as we're thinking about, especially female patients, when they're coming in with these symptoms, they're coming in with chest pain, with heart palpitations, with shortness of breath, a little anxious. We're often, and not just women, but men as well, written off as, oh, you're just stressed. You're just stressed. You need to work on your stress. Well, if we don't get to the root cause of that stress, right, then how can we work on it? And we'll continue on to talk about some more effects here. So this HPA axis that I've talked a little bit about, the hypothalamic pituitary adrenal axis, is stimulated when our body experiences stress, especially, fear. And chronic stress can cause increased activation of the HPA axis, which can lead to immune system activation, or hyperactivation or hypoactivation of the immune system, can cause patients to develop chronic fatigue, can cause metabolic disorders like obesity, diabetes, um, HPA axis dysfunction can lead to an increase in mood disorders like anxiety and depression, and can lead to an increase in immune and autoimmune disorders. Um, Also thinking about the musculoskeletal system, the increase of all of these glucocorticoids and catecholamines like epinephrine and cortisol can cause chronic muscle tension. So think about the last time you're really scared of something and you really tense up. This is happening for patients all the time. When they're experiencing stalking and they're always afraid, they're constantly having that chronic muscle tension, which can lead to chronic pain. Um, and we'll talk about how that can affect the activities of daily living in a second. But we also often hear about patients that have experienced stalking and other forms of sexual or intimate partner violence having these GI issues. So, constant GI upset, abdominal pain, nausea, increased acid reflux, and appetite disturbance. Kind of depending on what that fear looks like. If it's an intense fear, like the fear that's going to cause activation of the stress response, the patient may have a little bit of constipation because our body is not worried about digestion when we're really afraid. So the patient can experience constipation. And then if they ever get to a point where they have gotten a little bit less afraid, maybe they're able to take a breath and be somewhere where they feel safe. Then once the body starts to process food again, they may have diarrhea. And we also see with patients with uteruses that they may have absent or irregular menstrual cycles. It can cause intense pain with the menstrual cycle, can also cause effects on fertility. And for males as well, can cause effects on fertility. Specifically, lower sperm counts can be caused by chronic stress. We can go to the next slide. Yep. So, some things to think about with activities of daily living. So, when we think about those activities of daily living, those things that patients are doing every day, getting up, taking a shower, brushing their teeth, fixing their hair, going out and grocery shopping, things like that. We have seen that patients that are affected by stalking or experiencing stalking have difficulty with memory and concentration, which, if you're experiencing chronic fatigue and chronic fear, chronic stress, of course, you're going to have a little bit of difficulty remembering things. Patients have had reported an increase in difficulty walking or climbing stairs. That can be related to that chronic pain and chronic muscle tension. Patients have reported difficulty completing errands by themselves. Of course, if you're afraid to leave your home and worried about what might happen next, going to the grocery store or to the pharmacy to pick up medication might be really difficult. And we can see, as a healthcare provider, if a patient is unable to go and get their medication, maybe they have hypertension and they're having difficulty completing their errands alone, then that could increase some health impacts from that, from not being able to take their medication. And patients also reported difficulty with dressing or bathing, and we know that these things can also be associated with anxiety and depression and other mood disorders that can be a result of this chronic stress because of chronic victimization. All right, so kind of tying that all together, um, thinking back to the patient that I was telling you all about, she was telling me about all these symptoms that she was having, some GI upset, hair loss, vision issues, chronic headaches. And, she was thinking, maybe I have some kind of autoimmune disorder. And as we're talking and continuing on, getting to know one another, um, she starts to tell me about some things that are going on with her intimate partner at home. He had been following her, had put a tracker on her car, was riding by her work multiple times a day. calling her constantly, contacting her friends and family. And, as she's telling me about this, I'm like, you're being stalked. You're being stalked. And it had not progressed to the point of violence at that point. And, as she's telling me more about the physical symptoms and we got to talking about how chronic stress can affect the body, that those kinds of scenarios and some like you all have put in the chat make it really clear how all of these things can be connected. Um, and, as we're thinking about this, we know that patients can be reluctant to disclose their symptoms because of previous negative encounters with healthcare providers, especially if they've been brushed off, if they know that they're having physical symptoms and they've been told, oh, it's just anxiety. You just need to manage your stress better, drink more water, get some exercise. And they may never want to disclose something like this again. So we have a unique opportunity here to create a safe environment for patients to address their concerns and improve their health outcomes. All right. So we're going to talk a little bit about healthcare as an entry point. Um, and so looking at this data here in a 2019 report on stalking victimization, of the victims who sought services, 73.7% receive services. 61.7% of those that receive services from counseling or therapy, and 7.8% received medical advocacy services. And I think this data is so important because it lets us know that patients are seeking out healthcare. And this is a time when we can intervene and get them connected to resources and make sure that we're addressing these health impacts that they're experiencing. Um, as far as choosing to disclose, we know that women who survive domestic violence or intimate partner violence are prompted to disclose their experiences to clinicians or other healthcare providers once physical violence or some kind of health problem has occurred. So maybe they have been physically injured and they're seeking health care. They're more likely to disclose at that point. Also, if the woman fears the perpetrator, they're more likely to disclose to a medical professional. And fear is most strongly associated with disclosure. So I think it's something to really think about that, when patients are coming in and they're telling us about something that has happened, they're likely truly afraid. And we really want to take that very seriously. I think, yeah.
Yeah, I just wanted to add that, just like with sexual assault, we know most stalking victims don't report, depend to anyone, right? Depends what study you look at, but certainly fewer than a third report to law enforcement. About 16% report to any kind of victim services, and that includes the ones on this slide here. And of course, there's a variety of reasons why a stalking victim might not report or seek further help. But to me, it makes a lot of sense that someone who maybe doesn't want to go through the criminal justice system and or doesn't recognize what's happening as a crime, um, might be more interested in dealing with their immediate health impacts. And same with when we think about victim services, again, there's no standalone stalking crisis center. And so if I'm being stalked by, say, an estranged friend, it's not an intimate partner, there was no sexual relationship, there has not been any sexual assault, it's not that intuitive where I go. Do I pick up the phone and call the Family Justice Center? Do I go to Rape Crisis, right? And all those places have folks who can help me actually, but that's not necessarily intuitive. And so a lot of times when folks don't know to name what they're experiencing as stalking and or know it's stalking but don't want to go those other routes, I think that it makes a lot of sense that addressing those more immediate health concerns, and saying, well, I don't want to punish anyone, I don't want, all those things, but I need to deal with my health, for me, so I can live a better life. And so having that lens on when they do come in can, like Lacey said, make such a difference in identifying that stalking, maybe for the first time, and helping get them to those resources that can be helpful, but aren't always that intuitive to find.
Yeah. Yeah. And as we kind of move into talking with patients or victims, I think it's, so important that we really focus on open communication and being non-judgmental. Um, I think the first thing to really consider, and this is, in healthcare, in all healthcare spaces, not just when patients have experienced violence, although we know that more than likely a large percentage of the patients that we come into contact with, no matter the context that we're in, will have experienced violence at some point in their life. Um, we want to be upfront about confidentiality and privacy and the limits of confidentiality and privacy, especially with regards to mandated reporting. If these incidents involve children or older adults, it's so important to explain to patients what we are required to report based on your state and federal statutes. So, leading with that information so that patients can make informed choices about what they want to talk about and what they don't want to talk about. Also, really important to have opportunities for you as the clinician to speak to the patient alone. So they come in with someone else, even if it's presented as, someone who they wanted to be with them. We know that there are some conversations that we want to have with the patient alone. And it's also important to know and be able to employ some strategies to de-escalate some of those situations where you may ask, a family member or whoever is with the patient to step out of the room, being able to explain why you need to do that, and, kind of de-escalate that if the person who's with the patient gets upset. Um, and, when and if a patient discloses something to you, we really want to validate their concerns, especially, these specific stalking tactics that some of you have put in the chat. You know, it may not be scary to me that someone left a dead flower on my driveway, but for the patient, that may be absolutely terrifying. So just validating, I understand you're concerned, and I'm concerned for you because I can see that you were scared. So let's talk a little bit more about this. Get that context. Can you tell me a little bit more about this situation so that I can really understand? Let the patient explain that context to you because you can't truly understand why they're so afraid if you don't have those background details, if the patient is willing to share them. Um, Important as well that we communicate what we can do for the patient and why we're asking for specific information. So if we're asking for further details, explaining, why you would like to know why having that flower on the driveway is terrifying, just understanding the context and explaining to patients why understanding that context is so important can really help kind of open the door for them to communicate with you more. And being able to communicate what you can and can't do for the patient. Um, Also, understanding those referrals that you can make and the resources that you can provide to the patient. If you have no idea what kind of victim service provider you can connect the patient to, then that would be a point where you would want to say, let me find out what resources are available. Hopefully, if this is something that you're dealing with on a regular basis or even a sometimes basis, you're aware of those referral resources and direct places that you can connect patients to. And we'll talk a little bit more about a warm handoff here in a second, but um, as you're thinking about what you can do as a healthcare provider, knowing your resources is so important. Being able to make those connections for a patient, and not just to give them a sheet of paper with a phone number, but to be able to actually make that connection with the patient with their consent. All right. So, some things to consider in healthcare spaces, especially those in, emergency departments and primary care offices where they're seeing patients. Um, are you screening for stalking to the degree that you screen for domestic violence or intimate partner violence and or sexual assault? And are you currently screening for domestic violence or sexual assault? Um, Important that, if you're not currently screening for domestic violence and sexual assault, that that you make that part of your regular process, and that you work on screening for stalking as part of that. And as Dana said earlier, we're working on those screening questions. So hopefully that will be a resource that you can use. Again, we talked about being familiar with community resources available for patients that report stalking, including if it's not related to domestic violence or intimate partner violence. Um, is your staff educated on stalking? And do they have that stalking lens when working with patients? How do your facility policies and procedures help ensure patient safety? So, discussing sensitive information with patients alone, strategies for reducing conflict when asking visitors to step out during these conversations. We talked about that a little bit. Some of that de-escalation training that's so important, how to have those conversations and what resources are available to learn more about that. And then how do your policies and practices help ensure staff safety? So if you're having these conversations or there's a potential that a stalker or other perpetrator may be present with a patient in the facility, of what do you have in place to ensure safety of staff? Especially, thinking about those providers that are in community clinics that are maybe not associated with a large hospital system. In my practice, that is where I have predominantly practiced as a forensic nurse, is in a community setting where I don't have access to a security officer 24/7. And I may have and have had perpetrators around the building or trying to get into the building while I was there with the patient. So having a clear policy on what to do in the event that something like that happens is so important.
Yeah, absolutely. And just to add on, I think we want to have reasonable expectations for what health providers can and cannot do. Just like Lacey said, your healthcare provider is not necessarily providing in-depth safety planning, but we're all safety planning with victims slash patients, depending. I come from more of a criminal justice place, so that's why I'm using the victim language more. But no one wants to get this kind of disclosure and then say, oh, okay, well, good luck with that, right? No, we want to be really at least validating the concern and getting them to that next right step. And that really is safety planning. At least that's the beginning of safety planning. And so safety planning is an individualized plan that identifies specific strategies and interventions that may increase safety. So we're talking about practical ways to decrease risk. It's going to put victims in contact with a variety of services, agencies, and individuals who can help. It's very confusing to know what is available and who's entitled to what. I've had so many survivors later say, oh, I wish I knew I was eligible for, say, victims' compensation, or that I, could have gone to the shelter even though it wasn't intimate partner stalking. And so, like Lacey said, really learning what resources are available in your community and being able to um, facilitate those connections, like she said, in a really warm and significant way, not just in a here's the number, but in a, oh, I know this person and, do we want to call right now and that kind of thing. And it needs to focus on their physical and emotional well-being. I think sometimes when folks hear emotional well-being, they think like, oh, it's this touchy-feely thing. But as Lacey explained, A, it's not okay for people to be experiencing constant trauma and emotional stress, and B, it has a physical consequence as well. And so we need to be thinking about it for all of those reasons. Some very basic considerations. Generally, you want to trust victim instincts. Victims always say that's not always, but often say that's their message to other potential victims, is to trust their instincts and that they wish other people had trusted their instincts as well. And so if they feel like something's wrong or not quite right, they're probably right. And of course, trust your own instincts as well as providers if you feel like there's something going on. Safety planning should evolve. So the average duration of a stalking case, this really shocked me when I learned this, not the high end. The average duration is 2 years. and 10% of cases last 5 years or more. And so what that means is that stalkers have time to change their tactics and strategies. And so while no, we can't read the future, we want to be thinking about what access to and information about a victim that offender might have and what they might do next. And so just because they haven't, say, shown up at the home yet doesn't mean they won't. Do we think they're capable of that? If so, let's make sure we have a bag packed and a safe place to go. And maybe we want to install a camera so we can catch them doing it. Also, that considering the stalker's next tactic, often victims are the best equipped to do this in terms of anticipating the stalker reaction. So, too often, victims are given kind of blanket advice that sounds good, but when you really unpack it, may or may not be helpful for that specific victim and stalker relationship. For example, victims are often told, well, block them on everything, right? Change your phone number, like change that. And sometimes that's helpful because we know that contact can reinforce the stalker's behavior. So some stalkers will see that and say, okay, I'm done. And other stalkers will say, how dare you? That was my favorite way to stalk you. And now they're showing up in person. Same with serving that protective order. Some stalkers will say, ooh, I've gone too far. I don't want to get in trouble. And others will say, you think this will stop me? I'll show you, right? And so asking victims how they think the stalker might react. And so you can plan, these are never always do this or never do this kinds of things. It depends on the situation. And that balance of safety and freedom. We'd all be safer if we lived in kind of windowless castles with no Wi-Fi, right? We'd all be safe, but most of us don't want to do that. Some of us might, but most of us don't, right? And so often safety planning is really restrictive to victims and not fair. It says, oh, you're being victimized. Well, why don't you make your life really small? And some of that's necessary for safety, but it can really, really impact their freedom. And so only victims can make those calls about what lines they want to draw, and they might be different than what you would do. Right. But all these choices of pros and cons. So it's really ideally connecting them with a victim advocate who can really talk through those pros and cons and help your victim make the decision that's best for them, with the understanding that these cases are dynamic and it could change in the future, and that's okay. The only kind of big picture safety plan, like I said, we often do recommend no contact because if they if the stalker calls 100 times and the victim picks up and says, I hate you, don't call me, tomorrow they're calling 101 times. So it can reinforce the behavior, but that disengage is not always possible or realistic. And so, if I was again stalking Lacey and maybe I'm old school, I call her all the time, and eventually she picks up. She says, you know what, I'm not going to pick up. I can't deal with Dana anymore. I'm going to change my freaking number. So eventually I call and get that this number is no longer in service. Am I the stalker going to be like, oh man, I guess I'll stop stalking Lacey and become a productive member of society that respects boundaries this day? Like, probably not, right? I might again escalate the behavior. And so recognize that, yes, that's cleaner from a criminal justice perspective. And so often we see a lot of victim blaming around that. Well, why did you answer the text? Why did you talk to them? Why did you share your location, right? When they might have good reasons for doing that. And at the risk of sounding a little twee, I do think in terms of the victim blaming here, that like, what did you share has become not the new, but at least as much of a, like, what did you wear? Right? Where we have the sense of, well, if you didn't want them to find you, why'd you share your location? The problem isn't that someone shared their location, it's that a stalker saw that location and felt entitled to go and cause harm, right? And so we can talk about risk reduction just like we do for sexual violence, but I think it's important to have that framing around stalking as well, which I don't always hear brought to the forefront.
Yeah, I really like that point that you made, Dana. I mean, we all have this right and reasonable expectation that we can live our life and post on social media and do the things that we want to do without someone taking advantage of that information, right? So something to really keep in mind when we're talking with patients about this is not to say, well, just make everything private and block and do all these things because for their safety, yes, that may be something that they want to consider, but they also shouldn't have to minimize their life, just like Dana said, um, because someone chose to take advantage of that information. And so, more from safety planning from the clinician perspective, you know, as the healthcare provider, you may not be the one doing the detailed safety planning, but sometimes you may have to be the one doing the detailed safety planning, depending on what kind of resources you have access to. Um, Regardless, you should be able to begin that safety planning process. Explain to the patient what that looks like. We're going to talk through some of these scenarios and figure out what works best for you as far as making sure that when you leave the hospital or when you leave the facility, that you're able to be safe, and providing those appropriate and relevant referrals. So, making sure that if you have a sexual assault center or a domestic violence victim advocacy center, that you have contacted them ahead of time or someone has contacted them ahead of time to make sure that they can provide services for a patient who is experiencing stalking, and that someone has been put in charge of making sure that this list is up to date, that all of these agencies are still available, that we have the right phone numbers, and that we're able to make those connections, and then providing that warm handoff. So not just handing the patient, a phone number or saying you can get on this website, but actually saying, hey, I know Dana over at the Victim Advocacy Center. Would it be okay with you if we call her together? And, kind of walking through that process, making that connection and ensuring that making the connection in that way is okay with the agency that you're connecting them with. Um, so, providing that, you and I have created this rapport together, and now I want to give you to someone else that can provide you with something that I can't provide, but let me make this connection, makes it where the patient is much more willing and likely to access that service.
Yeah, thanks so much, Lacey. I think that is all so true and so key. And again, when we think about healthcare as a potential entry point, whether that's to criminal justice, to victim services, to any kind of service that they might want for their own safety and or healing, um, it's really critical as part of that coordinated community response. And we really need that coordination. And like Lacey said, it's really having the relationship ahead of time so we're not blindsiding our victim service providers. And also because a lot of folks are under-resourced on stalking, having that conversation with them about, how can they maybe build up some of their stalking response so that when you hand that victim to them, you feel confident that they'll get the range of services that they need and deserve. And thinking about what in your community, what are those different entry points, if it's medical, if it's healthcare, if it's a religious community, if it's, what are the places and how can we involve anyone in this response? Because what we really need is that coordination, which is much easier said than done. But within the healthcare space, we can certainly be identifying and building those partnerships to make sure that we're getting victims to the right place. And I will say too, after this, what, hour and a half, you now know more about stalking and certainly more about the health impacts of stalking than most people in our field. That's just the reality of the situation. And we need to realize our system's not set up for stalking. It's really set up to be incident based. And so there's no one whose number one job it is really to help stalking survivors. It kind of has to be you in whatever role you play, recognizing, hey, I see the urgency here and helping walk victims through this imperfect system and get them to the places that they need. So I know it's easy for us to sit here and say, like, think about that, consider this, could it be stalking, right? But you're the ones actually, excuse me, keeping victims safe and healthy. It is all easier said than done, and we totally understand that. So truly thank you for the work that you do and for tuning in to learn a little bit more about stalking today. Here's my contact information, and I'll toggle between myself and Lacey. And again, this is part of the Vital Signs Project. This is just the beginning of what we're hoping are a lot of helpful resources and trainings on health and stalking. And so please reach out with your ideas, what would help you, what you're already doing that's working, etc., because that's what we're here for. We also offer individualized training for an agency, whether it's victim services or healthcare, etc., as well as multidisciplinary. Definitely check out the Spark website. Right now, that's housing our current resources that will include this webinar recorded, as well as a short video on the health impacts of stalking, um, fact sheet, infographic, and other ways to learn more about stalking and get started. So I know we're at time here. I can stick around for a couple moments for questions, but of course I understand if folks have to go, especially our interpreters. So thanks so much for joining, and to our interpreters, and thanks for co-presenting with me, Lacey.
Yeah.
Um, yeah, it was my pleasure. And with that, I will take a look at the Q&A and see if there's a couple of these we can get to. See. I'm just going to open this up here. Okay, someone asked, is stalking considered domestic violence? I know it can fall under the umbrella of domestic violence. What makes it not domestic violence? I'd say it's not domestic violence if the offender is not intimate partner violence related in any way. And when I say domestic violence, I mean dating violence as well. And so, you know, if there's a lot of relationships, including the stalking of clinicians, which could be intimate partner violence, but say you have a patient stalking a doctor, right? That's not domestic violence because it wasn't about the relationship. But it wasn't about an intimate partner relationship, but it's still stalking. And we often see workplace disputes. Like I was actually at a medical, I had a temp job at a medical school, and they would train actors to come in and act out having certain ailments, right? And so that the students could diagnose them. One of those actors was acting in a kind of aggressive way and was let go. And then he began stalking the program staff, right? And so for firing him, so showing up, sending threatening messages, etc. So I would say that's not domestic violence, but it is stalking. That being said, the services for that person are generally housed under domestic violence services. And that's true for victim services as well as on the criminal justice side. If there's anyone who is primarily tasked with investigating stalking, they're usually under domestic violence. And I'd say that's not wrong, but it is incomplete because the majority of victims actually are not intimate partner violence related. So I hope that answers your question. That being said, we see a lot of the same power and control dynamics and feelings of entitlement that are, part of that intimate partner offender might also be present with our non-intimate partner offenders. Let's see. Yeah, I feel like these other questions I'm seeing are more about kind of what is stalking. And since we're over time, we have so much on our website about what is stalking, and we're looking to develop more, but feel free to email me if I didn't get to you. Um, and again, we're available for further training, etc. So feel free to contact me, or, oh no, I didn't toggle to Lacey. Here's Lacey's too. So yeah, all right. Well, thanks so much. I'll wrap it up there unless Lacey has anything you want to add.
No, I don't think so. Just thank you for letting me be a part of this. And if you all need information, further information about forensic nursing or the healthcare aspect, please feel free to reach out and look at the resources on our website as well.
Hey, wonderful. Thanks so much, Lacey. Thank you all. Have a good one.
Thanks, Dana. Thanks, Lacey. Talk to you soon.